That IV we're going to put into your veins, all right? So wherever those may be on your hands and your arms, wherever else, that's our best bet for giving you fluids and medications. But oftentimes that's not an option for us. Sometimes many of the IOs that I've placed in my career have been on burn patients, all right? So I didn't have any access to veins because their arms and legs are burned. So I have to go to somewhere else, and it's called an intraosseous. So what does that mean is we're actually putting a needle via a drill directly into your bone marrow. We're actually screwing it into your bone. People think this is horribly, horribly painful. There's several YouTube videos on it. You can look it up. I've had 2 placed on me just to see what it felt like, not because I needed them. When they're actually drilled in, it's probably in a 0 to 10 scale, 10 being the worst pain I've ever felt. Probably about a 2, not too bad, kind of like having a shot. When they actually get into the bone, maybe a 3. When they go to aspirate or pull bone marrow out, probably goes to 5. And when they go to flush it, yeah, it gets a little painful. That's 7, 8. So that's when kind of pain comes in. We can give just about anything we want to through the intraosseous needle. So IV fluids, blood products, all medications, and it gets to your heart just as fast as it does via the venous system or your veins. It's not our first go-to. We don't like to just drill into people's bones, but if we need to, we will. They're only good for about 24 hours and they have to come out. But we can put them in the arm or the leg. Some of the old military ones actually went into your sternum. We no longer use those. So the videos you're going to see coming up here are going to be from the product. We don't endorse anything here, but EZ-IO is kind of the staple of most people use to put in intraosseous needles. So you're going to see a couple different things on that. And after you watch the videos, I'm going to bring Kylie up here. I'm going to kind of show some landmarks again on where to find these landmarks, how we do it.
I will be demonstrating the proper insertion of an intraosseous needle in the proximal humerus. Proximal humerus has many benefits, one of which is it's a large target. And just to appreciate how anterior to the midline the proximal humerus lies, one can take the palm of your hand and actually palpate the anterior portion of the proximal humerus with the palm of your hand. The patient's hand should be placed over the abdomen in order to help internally rotate the humerus to keep the intertubercular groove, which is where the biceps tendon is, medially and out of your field. The site of insertion is the greater tubercle, which is on the anterolateral aspect of the upper arm. In order to find the proper landmarks, I'm going to go over some techniques that you can use in order to feel the proper bony anatomy. The first thing that should be done with the patient's hand over the abdomen and the elbow tucked in and the arm adducted against the body, one should place the ulnar aspect of the left hand, in this case, in the axilla to help define the anterior border and keep myself out of the medial aspect of the arm, which is where the brachial plexus resides. The other hand should be placed in a perpendicular fashion in the midline of the upper arm, and where my thumbs will come together will define a line over which I should be palpating to feel for the surgical neck. The proper target is about 1 or 2 centimeters or 1 finger breadth above the surgical neck. So I'm using my hands in order to define where along the upper arm I should palpate, and palpating up and down I will feel for the surgical neck. It will feel like a golf ball on a tee. Where the golf ball meets the tee, that's the surgical neck. The proper placement is approximately 1 or 2 centimeters or approximately 1 finger breadth above that. So I've determined my landmarks. I'm eyeballing where I believe I'm going to be putting the needle. And I want to make sure I'm putting the needle at approximately a 45-degree angle, and I'm flush and perpendicular with the plane of the skin at that insertion point. So you're going to feel a little bit of poke here, okay?
Okay.
And that's it.
like a big Band-Aid that keeps it into place. And so that I can watch the site. You doing okay? All right, you're going to feel a little bit of pressure. I'm going to be pulling back to make sure we're in the right place, and we are.
Video demonstrates average time for medication fluid infusion from the humerus to the right atrium with the EZ-IO. Individual results may vary.
So you've kind of got the gist on how we do the IO, kind of the process behind it. I'm gonna kind of show you some things I'm preparing, things needed to set up and why we do it. So I've got down here several different things. It actually arrives, this is kind of where EZ-IO, you're gonna see this, especially the PA students, you're gonna see it looking like this in your hospital. Usually it's gonna be a yellow bag. Everything's inside of here. Your packages, you've got a couple different things, different sizes. The longer 45 millimeter are going to be for your humerus, right? Or for the high school students, your upper arm, okay? The smaller ones are going to be for your tibia and kids. So you can see the difference in these, the lengths of these. All right, the biggest thing I want you to know about these is it is imperative that you've got, when you actually enter the skin and touch the bone, that you've actually got at least 10 millimeters sticking out above the skin. You have to have at least that much to get into the bone marrow. All right, so when you get through the skin, you need at least 10 millimeters. So from here, I'm going to attach it, and it's magnetic. All right, you heard it click. Okay. Now, inside of this package, you're going to have a pigtail. Ideally, we want to flush this with lidocaine. It makes that, when we go to flush actually in the bone, it makes it a lot less painful. Still hurts. This is just normal saline, which will work also. This is to push and twist. All right, so push, twist it on, and I'm going to flush this through. Just prime it all the way up. Okay, so that's ready to go. I've got my stabilizing pad, which actually goes around this needle. It's kind of hard for me to, I'll demonstrate here in just a second. All right, Connie, you want to come on up? I told Bruna that she could actually drill my IO, but she refused to do it. So it's Bruna's fault. All right, a couple of things. So my landmarks, right in the middle, right in the axillary area. Okay, both fingers down. I'm just palpate all the way up under humerus, and I'm feeling for basically. It's like a golf ball on a tee. So I'm feeling from the most proximal point. Once I find it, I'm really gonna do it. I'm gonna go all the way in and let the drill fix. Let the drill actually do the work. You don't want to force it all the way in. Let it spin and go all the way in. You're gonna feel it kind of get soft. That means you're actually in the bone marrow at that point. So once it's kind of gets soft, you bury the hub, it goes all the way down. We're going to, I'll come back over here so you can see this a little bit easier. This is actually in the bone. We'll withdraw that center needle. Okay, so this sits in the skin, flush. From here, we're going to screw this on. And the first thing I'm gonna do is I'm gonna aspirate. So high school students, that means NPA students, if you haven't heard this word before, I'm gonna pull back on a syringe. Sometimes I'll get bone marrow inside of here, sometimes I won't. So you aspirate, see if you got bone marrow. It kind of looks like spongy type stuff. And then I'm going to flush this through. So keep an eye on your patient when you actually flush this, because this is where it gets to be pretty painful, all right? We're taking the bone marrow inside of your bone, and we're kind of expanding it out. So it does hurt. So at this point, we're gonna flush it. You can see it coming out on the end down there. I flush it actually under pressure. So while I'm flushing it, while I'm pushing the syringe down, I squeeze it and walk it off. All right, it gives me good positive pressure inside of that. All right. before that, I should have actually slid this up, but this actually tapes to the patient's skin, right, and it stabilizes it. Because it's like basically a nail or a screw inside of the bone, we need to stabilize it so it doesn't move around. If it starts wallowing around, the fluid will leak around the needle and not actually get into the bone marrow. So it's imperative that we actually lock this in, okay? So from here, this would attach onto the top of it. All right, and it looks like that on the skin. Okay, so you remember these are good for 24 hours. Past that, it needs to be probably pulled out. The risks of these are osteomyelitis, so infection of your bone. That's the biggest risk. That's the reason why Bruna refused to do it on me, but I trusted her, but we decided not to do it. And obviously damage the bone, insertion site, you can get an infection just like any other IVs. Really, the only medications you can't give through here are going to be like chemotherapeutic drugs. They really aren't approved, but they don't, if we're doing this, we're not pushing chemotherapeutic drugs. Another thing you need to worry about on this also is that move them around. So if it's an emergent type situation and they've got this needle sticking out of their bone, you go to move them around, you can get caught on stuff. On my officers, I got to worry about their plate carriers and things like that, that it doesn't bump against it. One last thing on the intraosseous, it has to be under pressure, all right? So it doesn't normally just drip in like a normal IV. You actually either have to put it under a pressure bag or you have to squeeze it, all right? Because you force it into bone marrow. So it doesn't just go in normally. So you have to squeeze it down. That's the only way to get it to flow. If you put it in and call it good and hang your IV bag and walk away, they're getting nothing. It has to be under pressure. All right, we see this all the time when Bruna and I do the trauma scenarios. They'll do a great job getting IO in, they'll hang the IV bag and they walk off. And they'll get no change whatsoever in the patient's status because the fluid's not actually flowing. It has to be squeezed in. PA students, if you're pushing D50, so dextrose 50, high school students, that's sugar water. So if your blood sugar is low, it's really thick. It's like pushing syrup. So even through normal veins, you really got to push it hard. Push it through bone marrow, it's going to take even more, all right? All right, so intraosseous, IO. We know why we do it, we know when we do it, and we know how to do it.